So welcome to Trusted Health's Flexible Nursing Workforce Masterclass, where Dan Weberg, will be hosting and facilitating conversation with the wonderful Dr. Danny Bowie. And we'll get to those intros, those more formal intros here in a second. But our goal with this report is really to shed light on the generational differences in what nurses are looking for out of their career and highlight the areas where profession is falling short of its youngest members' expectations. So historically, nurses have had very linear careers in which they pick a specialty and sort of stay in that specialty and move up either into management or teaching, but really sort of stick around that clinical ladder related to their specialty. But today we're seeing very different needs from our next generation of nurses, the ones that we need to recruit and retain in order to shore up some of the shortage that's happening. So by and large, these nurses aren't interested in such linear progressions. From our research, many of them are not interested in becoming nurse leaders, which is also very concerning because a number of our experienced nurse leaders are starting to retire or choose other things to do. And given the longstanding nursing shortage and record number of nurses who are retiring or considering leaving the profession as a result of COVID-19 and the pandemic, we truly believe there's a crisis in the profession, but I think there's some solutions to address it. And so Danny and I will be exploring some of those solutions and hopefully giving some insights that you can take back to your organizations to do all the things we're doing now, which is fix our care environments, make sure our nurses are supported, and recruit and retain the best talent to care for our patients. So with that, just a reminder for those that just joined, if you have questions, please type them into the Q&A button on Zoom, and we'll get to those near the end. All right, let's get started with the amazing masterclass here. So again, my name's Dan Weberg, Dr. Nurse Dan, if you can follow me on LinkedIn, but I am a nursing executive currently stationed at Ascension Healthcare as a National Vice President for Nursing Transformation. I spend a lot of my time on LinkedIn, which many of you know that, and I was at Kaiser Permanente. I was an alumni of Trusted Health as well, and have done a number of things. My passion really is how do we prepare the leaders and the nurses of the future, and you have an opportunity to, if you stay to the end, to get a copy of our book, which is Leadership in Nursing Practice, which has a chapter by the lovely Dr. Danny Bowie. So Danny, I'd love for you to introduce yourself.
Hi, Danny Bowie. I'm excited to be here. I just wanted to let the group know I've spent the last 10 years of my 15-year career solely focused on nursing workforce challenges, and that relates to staffing, scheduling, float pools, and agency management. I'm passionate about the work, and during those 10 years, I've led 3 large health systems through workforce tech implementations, looking at updated operational models, adoption of best practices, and also looking to improve retention and decrease agency spend. Additionally, I spent my doctoral journey unpacking the nurse scheduling problem and built a predictive model to help frontline managers build better schedules. So joining Trusted for me was a no-brainer. Our priorities and our goals aligned. We wanted to solve the nurse staffing problem from a nurse's perspective and bring relief to our burdened frontline nurses and managers so they can focus on caring for their patients and healing our communities. So I'm just really excited to be here and share the work that I've done so far, and also excited to be a part of the Trusted team and all the energy and innovation that exists within this awesome team.
Thanks, Danny. And when we called it a masterclass, we weren't kidding. So Danny literally has her doctoral degree focused on staffing and predictive models of staffing, which for the nurse leaders and nurse execs on the call, I know this is of top of mind because it is for us at Ascension as well. So I'm excited to explore this with Danny. We're going to give both of our experiences across the organizations and also some recommendations and solutions we think based on the evidence that we have from both our experience, research we've done, as well as some of the work that Trusted Health has done. So let's get started. All right, so today's plan is we're going to do a quick sneak peek into the book, just to whet your appetite and share. That book launched a couple weeks ago, and so we're excited to share just a little bit about that. We're going to give you some real world experiences and lessons in building a flexible workforce, and like we said, Danny has the most relevant experience you can have here, and so we'll tap into her knowledge, and I'll give some of my insights from the big systems that I've worked at. And then we'll wrap it up with a look into the future of healthcare staffing and how we are creating, or how you can create, a talent-centric world, and enable that both with technology as well as cultural shifts, in hopes to tap into that talent pipeline and bring them to your organization, really differentiate yourself as we move through just a crazy time in the labor market for clinicians. So don't forget, stay around to the end. We'll have a link for you to fill out to get a free copy of Leadership in Nursing Practice, the 4th edition. So this is a book that myself and my co-author, Kara Mangold, who's at Mayo Clinic, a nurse leader at Mayo Clinic, wrote. This was handed to us by Dr. Tim Porter O'Grady and Dr. Kathy Malik. And we've done now 2 editions with it, updated it with interprofessional practice, policy, burnout, toxic leadership, and a brand new chapter to this edition is one that Danny wrote specifically on nursing staffing and nursing staffing technology and the models that she has done in her doctoral work and applied at different organizations. So if you stick around, you get a free copy of it. It's awesome. It's hot off the press. And this book is also adopted in over 100 nursing programs across the country, mostly in RN to BSN or master's level leadership programs. So real practical advice for you, a great opportunity to get into the latest evidence, and written with the innovation as the background. So, because you wouldn't expect anything less from Dr. Nurse Dan here. So excited to be able to share that with you. And if you do get it, please send me feedback or send us feedback. We'd love to hear how you're using the book. So stick around to the end. All right, enough with that. Let's get started into the content you're all here for. Let's talk about the changing workforce. So we're going to go through some of the statistics and the data that shows how the workforce is changing. I'll turn it over to Danny to run us through this. So Danny, take it away.
Yeah, the workforce environment health systems are facing across the country is challenging, to say the least. A potential 3.2 million shortage of healthcare workers that we're expecting by 2026, compounded with a staggering year-over-year nurse turnover increase, is creating a very chaotic and demanding practice environment for our healthcare leaders and our clinicians to do their best work. In fact, a recent survey of over 3,000 nurses revealed record high levels of burnout. Interestingly enough, flexibility was a key theme as to what nurses were looking for in their careers overall. Like their peers in other industries, nurses are looking for more control over their schedules. And in fact, nearly 3/4 of them said their experience as a nurse would improve if they had more control over their schedule. When asked the question, beyond increasing pay, how can leadership improve your experience as a nurse? Nearly 2/3 said offer more flexible scheduling. So we're capturing a theme here. However, as nurse leaders and executives, this request is a lot easier said than done due to the complexity of our workforce environments. So let's dive into some of the material that can help you as a leader learn how to bring practice change to your current health system.
So we're going to be launching this book, which is super exciting. It launched 2 weeks ago. And, really it's like we said, the focus of bringing together the things that are not talked about in leadership. And so, one resource you have as you're navigating the talent and the talent pipeline and the recruiting and retention is really focusing on staffing, culture, professional practice, shared governance. All of those themes are within the book. So it's a great resource for you as one of the tools to use to solve the problems that you're working on at your different health systems.
I'm also, as Dr. Dan was mentioning in this awesome book that's been recently published and released, I'm excited to share my recent book chapter, The Era of Digitization and the Nursing Workforce Management, an overview of contemporary nurse scheduling and staffing practices. This chapter will provide a really nice comprehensive overview for nursing workforce management and will allow the reader to learn the core principles of how to start to build flexibility into your workforce programs and strategies. In the chapter, you will gain an overview of nursing workforce principles, review the core functions for nurse scheduling, staffing, patient acuity to help you build foundations for best practice, do a deep dive into the interconnectedness of scheduling and staffing, organizational design, policy and technology, and how each piece works together. Learn about the current digital state of nurse scheduling as it relates to forecasting and predictive opportunities for the future, which is obviously one of my passions. And then learn about advocacy work for nursing and how we should be using our voices for legislation and opportunities in the future. It's a fast and easy read, and I'll give you some practical steps for your operational management and best practice opportunities that you can implement into your environment.
Yeah, and again, this is a practical book. This is one that's meant for nurse managers and leaders to use in their day-to-day work with examples, case studies, and questions to really help you up level your team. So, Danny, just so thankful for you writing that chapter. It's a big deal, and we're excited to see the reaction as people begin to read the text.
Yeah, would love the feedback. Secondly, if the book chapter is just a little too long, there's also a really great article, How to Build a Flexible Nursing Workforce Program, Making the Dream a Reality, recently just published. It's a nice article for readers to also gain a comprehensive overview of how to build a program and learn from a case study where this was accomplished for a multi-state health system. Again, core components of the article will include an overview of staffing and scheduling policies, best practice recommendations for staffing and scheduling, and how to select workforce technology and ways to build flexible workforce pipelines. I think that, if you want, you should read both the chapter and this, because this is just a synopsis of what you're going to get in the chapter, but both of these will allow you to have pearls of wisdom that you can help bring and implement into your practice environment.
And Danny, we have a question really quick related to this. Is there a link for the article, or where can they find the article?
Yeah, I do have a link for the article. I'm happy. I have it on my LinkedIn, actually. It's already linked under one of my experiences, but I'm also happy to share it with however the trusted team we can get this out afterwards.
Yeah, so we'll be sending out a package of these resources as well, along with the link on how to get the book. And so it'll be in that package, and then we'll try and throw it into the chat at some point here as well. So great question.
Perfect.
Awesome. All right.
And then lastly, another hot off the press item is I participated on a nursing staff think tank with healthcare leaders and direct care nurses and other stakeholders for the last 3 months to help develop national recommendations to improve acute staffing. The think tank was a collaboration between the AACN, ANA, AONL, HFMA, and IHI. 6 priorities were identified by the group. So we looked at work environments, diversity, equity, and inclusion, stress, injury continuum, flexible work schedules, innovative care models, and total compensation. Specific actions and outcome measures are included with the recommendations. And I definitely would encourage you to check out those recommendations of some really great thought leaders across the country, spending their evenings trying to help solve this problem and give some practical steps. So I believe this also should be in the packet that we'll send out.
Yeah, and I just posted the link there as well into the chat for everyone to the think tank as well. So again, this is the cutting edge information happening at all of our professional organizations, as well as the latest research on it. So we're hoping we'll now shift. Let's see here. I click the right button. Now let's shift into some of the 5 things to think about as you build a flexible workforce. And again, we know our incoming workforce is demanding flexibility. We know 12-hour shifts are detrimental to our safety and error events. And we know that the current structure of overtime and mandatory work is not sustainable or healthy to our workforce. There's been several events lately that have highlighted the need for nurses to take care of themselves. And one of those interventions can be flexible work. And so we have to break our mold. We have to think anew and act anew in order to disenthrall ourselves from the past. One of my favorite Abraham Lincoln quotes. So we're going to go through those 5 things. So Danny, take it away. What are those 5 things we can do to build a flexible workforce?
Yes. And I think this is also nice. It kind of lends itself to a chat that was just put in by Jennifer. But you first start with a flexibility mindset. So it's essential for a nurse leader to embrace and re-envision workforce programs. And it's important to evaluate yourself as a leader, and are you open to new ways of operating and that flexibility? And so I would just encourage all of you to ask these really pertinent questions. Is there a way we can remove a paper or a manual process in your current practice environment? Is there any cross-training or job mobility opportunities in your organization for your workforce? Can you develop a search team? What would that take? Is there any new schedule patterns or self-scheduling approaches that would really help benefit your workforce and bring that flexibility? Or are there any preconceived notions that need to be reframed in your own mind, such as like, I've tried this before, it didn't work, or only nurses can do this? There's lots of sacred cows I think we operate with as a nurse, and I'm guilty of it too. And so every time I start a project, I really challenge myself to think differently about this and dream big, and really evaluate what do we need to do to make a difference. And so take the time, ask those thought-provoking questions, and then start to match those questions with your operational reality. And I would just encourage you to remove any limits and think creatively as we start to embrace what the workforce is really looking for.
Yeah, and I think that's a key point there, Danny, that you mentioned, which is the dogmas that we hold on to, like nurses only like 12-hour shifts because they get 4 days off afterwards, or no, it's fine. They love picking up overtime because they like that. They like the paycheck. Those are all things that are triggers and assumptions we have in our head, where there used to be data related to that, but now we're finding more. So let the evidence guide your thinking there, and free yourself to think about, what if you could work, nurses could work 2-hour shifts. What if they didn't have to work 3 shifts in a row at the ICU? They were able to pick up shifts in that ambulatory clinic and do things that maybe were less stressful when they have a stressful clinical assignment. All of those things, matching the talent and the skill set rather than just slotting people into 4 North, the 4 North unit all the time. That linear solution doesn't make sense. You're working in a complex problem. The linear solutions don't work. So free yourself and think, what if you could match the right talent to the right patient load at any given time? And that'll free you into some of these other solutions. So half of this work is letting go of the things that you hold so close and dear, and let the evidence guide your way.
Absolutely. Once you start to dream and think, now it's important to look at your current practice environment and say, okay, I'm dreaming of this. How can I make this a reality? So I want you to think about, like, what were the thoughts or the ideas that you came up with? And, flexible programs can have a variety of approaches, as I mentioned before. So as you heard me ask questions like a surge team, an internal travel program, new scheduling approaches, upskilling and cross-training your workforce. Once you land on the type of flexible program you want to build, you should move into some core functions to help bring that to life. And as you know, as nurse leaders, cost analysis is going to be a key function as you start to build that program. So what would it cost to build this? What would be the ROI? And oftentimes the ROI that we look at, which I would encourage us all to continue to look at, is reduction of agency, premium spend targets, and then of course, any way to continue to improve retention and turnover targets is going to be a win for that health system. Compensation models should also be included. So as you land on the type of program you want to build, for instance, if you're building an internal travel program, key things in that comp model would be, what's their base pay, housing stipends, and how do you factor that in also to their pay, use of incentives for open shifts, and what level would you be offering, vacation time. It's just important, I believe, as a nurse, to pay for flexibility and to continue to comp our nurses in building new skills and ability to help support our patients. Also, if you do build programs, I'd encourage you, get that job description set. If you have existing job descriptions, you need to match it to what you're doing for the new and make sure there's no competing priorities. and ways that you can help streamline the process and bring that standardization, because that will set you up for better management of your flexible workforce. And we'll talk about that in the next slides. And then finally, your management of the flexible workforce. It's important to identify those leaders and the responsibilities with the new program and provide ample executive support to that team when you launch something new and you land on that idea, and ensure it makes sense from a cost perspective.
Yeah, and these are great things to think about. And remember, this is all about data too. And so you need the data. You need to work with your HR partners to pull this data. You need to look at trends and things to build this out. And most importantly, you got to get off paper. So if you're doing this on paper, you don't have the real-time data to make these decisions. And so move to some technology. I know we've worked with organizations that had 450 spreadsheets that were 20,000 lines long of scheduling and things. And I think there's definitely better ways. So start with that core as well. You need the data to make these decisions.
Absolutely. Yeah, and once you settle on the program, develop those foundations of analytics and support, it's important to think about, well, how do we operationalize this program? Again, your internal travel or regional float program, use of per diem, search teams, it all requires a unique operational practice and some dedicated effort and coordination there. So some key areas to address or modify will include, of course, the management structure, like we talked about, new policies for the program, which I speak to in the book chapter and even in the article. And you're going to hear me time and time again, get your staffing, get your scheduling, your incentive policies set and standard. That will really set you up for success to lead a program, to speak the same language, and in fact, use technology to start to capture that data. That's going to be really important in building your flexible programs. Standard SOPs, so usually you derive those from your policies. That will allow your team to move in coordination. Oftentimes, defined health systems will not be coordinated, and you'll see one hospital outbidding another for the same workforce, and that's just detrimental to your workforce as well as your operating budget. And then new organizational teams. So do you need someone like a staffer or a scheduler, or do you need central resource team management like staffing offices, et cetera? So think about what you need to make this happen from a labor perspective. And then most importantly, workforce technology will automate and extend the reach of this program. So gone are the days of email and phone calls and paper, if you truly want to get flexible and you truly want to get innovative in this space.
Yeah. So again, doubling down on the technology and the resourcing it too. Standing up an internal travel program takes many resources. One person can't just run it usually. And so you have to invest in this model, and you can show the ROI pretty quickly, I believe.
Mm-hmm. Absolutely. And here it is, workforce technology is essential to any flexible program. As I mentioned, paper, phone calls, emails, which I know we still use, and there may be a space for this, but they lack coordination, visibility, and the analytics you're going to need to run a comprehensive program. So when you're evaluating, what do I need for my workforce technology? First, you need to understand what program you're building. But most importantly, as you look at workforce technology, there's some core features that you should consider for your organization. So ease of use from the end user perspective. Is it nurse friendly? Is it mobile first, which is key? Flexible and adaptable to your organizational needs, such as your incentive policies or the management of your workforce layers. Like, do you have float pools, internal agency, PRN use? That's going to be a key feature that will be important as you look at tech. And then, do you have an enterprise view? Is it holistic? That you need that, especially for large integrated health systems. And most importantly, I've seen tech stacks, but they lack in the analytics or the data reporting capability. So ensure that there is the ability to pull meaningful information, because you just did all that hard work with standardizing your policies, your SOPs, your team. And now that you have that standard language, you should be able to pull it from your technology to make both retroactive look, how did we do, and then forecasting ability as well. So that's where it's at. Dr. Dan, do you have anything to add to that one?
Yeah, I mean, I think my dream in this whole thing of flexible labor is to break out of that mentality, like I said. And I always pick on 4 North, and I actually was giving a talk the other day in Florida, and I kept saying 4 North, and the nurse manager for 4 North was actually there, and I just, I made it up, and she's like, "Oh my God, stop making fun of my unit." But this idea that we hire people into this like physical unit and we don't let that talent spread throughout the organization. And technology is what's going to enable that. So the way you can put in nursing competencies, skills, and career goals into a system and then match that to the patient needs at any given time, that's where flexibility comes in. Because now you're not having that, 50 nurses in the ICU. You have 60,000 nurses in the case of an Ascension or a Kaiser. That's your talent pool. And now you can pull that talent and move it to the place where it's most needed so that they're happy, the patients get what they need, and it's the most effective way to staff. And so I think we have to break ourselves out of this idea of kind of the geolocation of hiring and think of this total talent pool. And the only way we're going to get there, especially in large systems, is through a technology enabled approach. So it has to be the backbone. And the more data you have, the better you can start making smart recommendations and delivering on that ROI. And so I'm a technology fan in this space. I think it's the only way we're going to move to a more flexible model.
Me too. Yeah. And then lastly, let's bring it home with one of the most important pieces as well, change management. You just did all of this hard work in building and training, and change management can be rough and it can be hard. It's important to remember that with any project implementation, your go live is actually just the beginning of solidifying that change. All the pre-work of planning, education was essential for the launch, but now the change management work becomes even more imperative once your program goes live. So some things to consider for successful change management once you've launched. One, sufficient training, your pre-go live, and then ongoing support the next couple of months once you've launched is going to make a huge difference for your frontline users. A true pilot phase. This will allow for a couple PDCA cycles for you to roll out organization-wide to gain feedback and modify the model as needed with some of those micro changes before you launch broader and bigger. Set up standing meetings post-go live to gain that feedback from frontline users, and I kind of call them the micro changes that need to be implemented. And then communicate. Use every forum possible. It takes a while for this to disseminate out to the ranks and to everyone that it touches. So just keep saying the message, keep sharing the vision, and then set the expectation of time. The change isn't going to happen overnight. And oftentimes what I've encountered in helping transformation for large health systems, it takes about 6 months to really get comfortable with the new program and to work out all of those kinks. So just give yourself time. Know that you're going to have some bumps along the way, and that's okay. Be comfortable in, reiterating the process. And then mostly stay committed to the vision. So you've set foundational framework for your vision, stay committed to that, and don't be too hard on yourself. It takes time, change is hard, but hold to that vision, make minor modifications where you can, and just know that it's just ongoing from this point forward once you really want to embrace and change the workforce space.
And I think the other piece is there's a lot of evidence on how to change systems as well, and how to lead change. And so that's a passion of mine. If you follow LinkedIn or any of my publications, it's all about how do you change systems. And so, let's not throw stuff at the wall and see what sticks. And this, follow the evidence of change, even if it's simply, following the diffusion of innovation sort of framework. There's going to be people resisting it. Don't let them overtake it, and really push forward because you have the data, you have the drive, and that 16% of people that are laggards that will never ever adopt the innovation are usually the loudest. But I think as change leaders, we have to say, that's great, you can be loud, but we're doing this anyway. And eventually the change sticks, and those laggards have a choice of adopting it or going away. And sometimes you got to help them go away. And I think in this framework, we're really disrupting decades of tradition. It's going to take a really strong change management process to make this happen. Yeah. All right. So we're going to now kind of shift to talking about some of our personal experiences in this work. But there's two questions I want to get to because they're sort of relevant to the last section here, Danny. So I'm going to read them out. So the first one is, actually, the first one, Naomi, we're going to get to that because you're asking about, Naomi's asking about making flexible labor within a union contract. And so we can hit on that. I think I can give you some insights from from Kaiser. And then Jennifer Misajet, hi and welcome. Good to see you. Has a question here as well. Is there a hybrid approach where you have traditional and flexible staffing programs to meet multiple needs? I keep hearing some nurses want traditional versus flex and want to satisfy multiple types of scheduling needs.
Absolutely. Yeah, there's a, and that's what I would encourage. It's not easy. I think, what we're encountering is a challenging environment, but there's absolutely ways that you can build some traditional and flexibility to help meet the demands of the workforce. For instance, some of your scheduling solutions could allow for some pattern scheduling here and there where it deems necessary. And then you can also plug in your self-scheduling elements that would help get you what you need for that flexibility and still allow you to meet your core staffing needs. So that's one avenue I would look at. And then also it's developing the opportunity for that upskilling or your flex teams, which could be another career path for your workforce. Not everyone has to be a part of it. They could apply for it. They could try it out actually, and then say, oh, I don't like this. And can you send them back to your home unit? So there's a variety of ways that you can, you don't have to do this radical change or overhaul, but you could find small tests of change to bring in for your workforce, whether that's scheduling or the flexible programs, and see, what's the appetite and is it sticking or not? So.
Yeah, and I think ultimately the equation is going to be you're always going to have a certain number of sort of non-flexible workers that just want that stability, don't necessarily want to have the craziness of a differing schedule or have to deal with that, and maybe they want their couple days a week and whatever the 8-hour shifts we'll call them, because we're going to get away from 12. That's a mandate from this. So you're always going to have that, but that's never going to be enough, and so you always are going to have this flexible model on top of it. So I think if you have both, then you're able to meet multiple generations, multiple needs, and have that opportunity for people to even move back and forth. And if you're in a large system that covers multiple locations or multiple states, even, you can set up flexible work in timing related to the season. So for example, at Ascension, we have Michigan hospitals, we have Florida hospitals. Well, there's a great cross-pollination of people that may not want to spend winters in Michigan and may not want to spend summers in Florida. And so you can actually use the location to create flexibility temporarily, but then create the stability for others, depending on how that goes too. So those are just a couple ideas as we move forward. So let's dive in, Danny, with some of our experience. We're going to start with yours, and really, what are some of the observations and lessons you learned in your work across all the different systems you've worked with?
A couple things. Executive leadership engagement and support is essential for the project's success. So it's really important for whoever the project lead is to build in a regular cadence of standing meetings for that executive sponsor to understand the project, remove barriers, and most importantly, frequently communicate the vision to their key stakeholders and also to the workforce. That's just a key foundational step that should be taken with any type of project, whether that's a flexible project or not. Additionally, frontline engagement from the beginning will help set that health system up to embrace the change and transformation. I really like using a shared decision-making model and vehicles and forums to help with the process from the very beginning all the way to the end. And that will help bring that engagement and that perspective that's really needed, because this oftentimes is work and tools and change that is very impactful to our frontline nurses. Again, give dedicated time to the pilot phase. I'm passionate about that, but oftentimes I've seen not enough time for a true pilot. And so the lessons you learned, you aren't able to implement into your other areas of implementation for that project. And that's sometimes as nurse leaders, we really need to stand up for that one, because what I experience is like, get it done fast, get it done now, which yes, I believe timing is important, moving fast is important, but you do need to give that time to learn and to readjust so that you do it better for your next waves of change. And then again, implementation is just the beginning. And that's often what I observe. Project teams and everyone planning, they're like, oh yes, we finally implemented. And then actually the work becomes a little bit harder and a little bit longer, the hours a little bit longer. And so just being mindful of that workforce transformation, it's iterative, it's ongoing. It doesn't end when you implement the change, it actually just begins.
Awesome. Thanks for those great insights there. And, for me, it's, I've worked at two of the largest nonprofit health systems in the country. And there's a few takeaways that I'd like to give you. One is, and I'll get to the labor one, and then Dr. Sam Younger, I see your question as well. So I'll make sure I hit on that one too. So the idea, and we just sort of talked about it, was you'll never ever be fully staffed ever again. And to qualify that statement, it's you're never going to be able to hire enough full-time employee nurses to cover all the shifts and all the flexibility and changes that happen within a schedule. So stop trying to hire 150 nurses to work in a 30-bed tele unit. Doesn't make sense anymore. So how do you have a core set of team members and then a flexible, whether that's internal float pools or external travel or whatever it is, to kind of fill in the gaps across the system? I think, really thinking with that mindset just shifts how you approach the thing. We talked about skill determining assignments. So not the 4 North nurse that everyone's a 4 North nurse, but you're a clinician with a certain set of skills, and there's a need somewhere in the organization for that skill. And so how do we match that more intentionally? And I think if we can move to this skill determining assignment rather than where you were hired into or what random shift you signed up for 3 months ago, hoping that the patients on that particular shift match the skill set you have. I think the more we can try and move away from that model, the more we're going to have a dynamic and successful nursing workforce and a better practice. The on-demand workforce is the future. There's going to be these shifts that pop up that need sort of this last minute thing. It's been part of scheduling forever, and we've had to make phone calls to our friends and beg and plead. But I think there's now technology that can fix that. And there's organizations really thinking about how do we fix that. And then the last piece is it's got to be driven by data. I've seen too many organizations and these large systems that I've worked in too, doing this stuff on spreadsheets, Google Sheets, and trying to make sense of all this data with millions and millions of data points with no analytics on top of it. So really focus on where is this data living and how do you make decisions based on it. So tech and data need to drive the staffing, not phone calls and emotion, is basically the takeaway there. But I want to address the two questions that popped up here too. Danny, I'd love to hear your thoughts on them as well. So Naomi asked, can you speak to navigating building flexibility into a workforce, specifically staffing and scheduling approaches in the setting of collective bargaining agreements that tend to be very rigid and steeped in historical perception of what's fair to the nurse? So yes, you can do this. Now, I could name some collective bargaining entities that may not be as open to this, but we've done it. And so at Kaiser Permanente, we shifted away almost completely away from 12-hour shifts in Southern California. So they do 8s, they do 4s, they have other models of hourly shifts. Now, is that a complete flexible model? No. But guess what? I was talking to them the other day, some of the unions, the nursing unions, and we were talking about how do we build flexibility into the collective bargaining agreement, because that's what their constituents are demanding. And if the union's getting in the way, then there's a way to negotiate around that. So I would say, in my experience working through collective bargaining in one of the gold standard organizations for collective bargaining, there's an opportunity for transparency. What are we trying to achieve, and how do we support the worker? And if those are the kind of goals that you have, then nothing's impossible. And I've really found very little resistance in those conversations. It's when we're trying to hide our intentions or trying to take advantage of different situations, that's where it gets kind of tense. But if we're doing this for the future workforce, and especially now coming out of the pandemic where staffing is so crazy, solutions framed in how do we support the clinicians in the front line, I think have a lot more weight than they may have had in the past, where things were a little bit more stable. Danny, any thoughts on the collective bargaining side?
Yeah, it's possible. I've built programs for very unionized environments. I think the key thing is it just takes a bit longer because you're going to have to go to negotiations for what you want to see change for the areas of flexibility, and whether that's your weekend, your self-scheduling patterns, your shift patterns, all those things. It just takes time, but it's possible. And so it's just important to really list out what's important to you and how you can work that into your negotiations.
Agreed. And then Sam Younger posted in the chat, how can you develop flexible models for high functioning teams like high acute care areas, i.e. ECMO or maybe specialty surgery, those type of things. And, at Ascension, we built an OR model for specialty care, or specialty OR model, where we cross-trained the entire surgical teams. So they had a primary specialty that they focused on, and we built the team dynamic around that. And the surgeon and the nurses and the scrubs and everyone they worked really closely together, but we cross-trained them to 2 other subspecialties as well, so they can move between those. And so that allowed for flexibility across teams, but also allowed for that high functioning area. So not everyone had to learn everything, which is a lot of times how we run ORs. They were able to specialize and build that high functioning team kind of dynamic, but also have the setup and the training to do some of the flexible pieces. The other thing we did there was guaranteed hours. And so if things finished quicker, or they didn't have to use PTO to get their kind of round out their full day of hours. And so that guaranteed hours really helped them have that safety net as well. And so they wanted to help. They were willing to kind of stay and do things. And so it's a couple of those cultural takeaways. We presented at AONL. So if you go into AONL virtual, there's our talk related to that OR care model, and we had a lot of interest in it. So it is possible in those high functioning teams too. Danny, I'm sure you have some insights here.
Oh yeah, for sure. It depends on what you're looking for. I'm going to go back to the tech stack. So oftentimes I was able to build high functioning teams because I was able to identify the skills and competencies in that workforce and then deploy them based off of patient condition and need. So for instance, our ICU nurses who are in a resource team had ECMO training, and we were able to see them quickly. And so when we had an ECMO patient that required more resources from our workforce, we were able to meet that need of getting those nurses where they needed to go to care for that patient. So the way we operationalized it was more in the tech stack to understand what their skill set and what we really needed to care for patients on the unit. And then we would cross-train our workforce with a small segment to carry some of those skills and certifications.
Great. Thanks for that. All right, let's move on. And I know, Dawn, I see your question. We'll get to it. In a minute here. So let's take a look at the future of healthcare staffing for a talent-centric world. I know we talked a lot about technology and the tech stack and the ability to do that. So Danny, I know you have some insights here. So let's go through them.
Absolutely. Yeah, excited to. As we're finishing up this wonderful webinar, now more than ever, we live in a talent-centric world. And in fact, that's exactly what the Great Reshuffle revealed. Employees now sit in the driver's seat with a new set of expectations around flexibility and autonomy regarding desired jobs. And many health systems are scrambling to meet those expectations. If we can't find new ways to connect and engage with our nurses, we know that they'll move on. And this is supported with recent trends of organizational loyalty at an all-time low. Additionally, the NSI has shown that nurse turnover is trending up year over year, and it currently stands at 18.7. And the average cost to replace a nurse is around $40,000. So this unfortunate trend is leading to a lot of excessive use of contract labor. We've experienced this as nursing leaders, a blown operating budget over the last 2 years because of what has happened to our workforce conditions, and then potential alienation of our existing workforce. So as we're managing everything that's happening, and those that have stayed with us and committed to us, there's alienation because of maybe their wages aren't matching what we would pay contract labor. So the problem is also exacerbated with the complexity gap as well. We have, experienced nurses retiring only to be replaced with new nurses who maybe don't have the skills or up to par to care for these really sick patients quite yet. So the workforce picture is somewhat bleak in what we've been experiencing this year and the last couple of years, and potentially what we're heading into in the future. Now, furthermore, as we talked about, if the workforce dynamics isn't enough to deal with, the tools that frontline nurse leaders have to manage the demand of the staffing, flexibility, they're siloed, they're disparate, they lack automation, and they can't provide that comprehensive view of the workforce for daily staffing operations. So it's leading to this constant cycle of over and understaffing scenarios, a lot of chaos, a lot of frustration from well-intentioned leaders and from our very experienced and committed workforce. But I believe there's hope on the horizon. And that's, why I talked about my excitement in joining Trusted and what we're offering for the future. We believe the solution for creating flexibility for the nurses and what they want, as well as the direct access to talent that health systems need, can be found in Works. And it will flip the script to make staffing a competitive advantage versus a risk for your health system. We're just going to talk very quickly as to what Works could offer you. And we know, and as we talked about, a workforce solution can't be just a one size fits all. So Works offers a three-pronged approach because the workforce problem is greater than just one approach. First, with Works, you have the ability to source talent directly and connect direct through that platform. Second, Works will help automate critical staffing workflows, which is imperative for managing your internal workforce and your external workforce to make sure they're joint commission ready and that they're skilled and have the competencies to work any shift anywhere based off of their specialty. This feature will greatly help your frontline leaders who often spend 60% of their time, that's what literature says, doing staffing and scheduling work, and yet they're still running up short with their workforce on the day of. And third, which is probably my favorite feature and one that I've yet to find in the industry after implementing major scheduling solutions, is Works will intelligently match shifts with the right workforce based off of those intelligent algorithms and configurable programs that we can help with your help with your health system. So what you want for your health system. This is a huge win for the front line and your managers. No longer do you need to call employees, post paper sign up on your unit. With the mobile first approach, shifts are offered to the most qualified and cost-effective candidate. Additionally, the nurse can select their preference and receive notifications for the shifts they want and are qualified to work. This is key. It removes the friction that oftentimes health systems have with their front line because of that over messaging for your open shifts, which I have experienced time and time again with managing large float pools, managing integrated resource centers for 40 hospitals. This is a game changer. And then I just want to say that I think that this solution will be something that will help health systems really embrace that flexibility and see what the future holds for this space and think innovatively and do things that we haven't been able to do yet that I've seen with other tech stacks. So, and that's it. That's the final, pitch for Works. We do want to know how we can fit that into your current workforce strategy and enhance your flexible workforce programs. I really believe the possibilities are endless, and we're excited to dream with you and dare to take on those workforce challenges of today to create a better future for our health systems and our workforce.
Awesome. Thanks, Danny. Yeah, Works is a pretty cool system. And I got to see it as it started. It's deployed at Mercy Healthcare in St. Louis. And it's game changing for them to optimize both their cost, quality, and speed of getting people into those shifts. So it's exciting what could happen. And I know it can help a lot of people out there. So if you're interested, please reach out because there's just a lot there to think about and kind of superpower your workforce. All right, so we have reached near the end, so we want to make sure we answer everyone's questions. So if you click the little Q&A button on Zoom and enter your question, it'll pop up for me, and I'll read it out, and Danny and I can tackle it. And so there's a couple in the chat, and there's a couple in the Q&A. I prefer if you could get them in the Q&A. It's easier for me to manage it, but we'll answer them either way, no matter what. So the next question is from Don Wilcox. Says, any models or ideas for pre/post in a level 1 trauma center? And I'm not sure what pre-post is. Maybe that's op. But any ideas you have for level 1 trauma centers? Is there any nuance there, Danny, that we need to look at?
No, I mean, typically level 1 trauma center is going to just have more acute needs, a larger workforce, and a more skilled workforce for some of the specialty services that you're providing there. So I think it's just understanding what is the demographic that you're serving and what is it that you need from your workforce to be able to provide that care. Sometimes acuity systems will also help us understand our staffing needs, so that's an option for the level 1 trauma center. But what we're recommending for build and what's been mentioned in these articles can be applied to a level 1 trauma center all the way to, you know, a rural facility who also needs cross training and maybe has a smaller workforce.
And Don clarified pre-op and PACU too. Are there any nuances with pre-op and PACU that you know about? Or is it all sort of the same bucket of suggestions?
Yeah, I mean, what we've applied here, you would build that specifically for the nuanced areas of pre-op, post-op. So, and if you need to create some type of flexible covering and staffing support, you would just build it for that program. I had an OR float pool, and so we would help with our OR staffing across 8 hospitals, and we oftentimes would pre-schedule just because that was something that brought more stability to our hospitals. But I guess I would need to know more about what exactly you're looking for to come up with a specific solution.
Yeah, great. And Don, please reach out to Danny. We'll have the emails here in the packet as well. I think the other piece is, you know, OR is always its special little world. Sometimes it even reports out of the nursing kind of world into the COO world, and so you kind of breaking down those organizational silos that are created and thinking about, you know, how do your ICU nurses help support PACU or vice versa. You know, pre-op can be an interesting place for people as well. And so how do you just think of it not as OR as its own standalone silo service line, but again, thinking about that flexible toolkit across your entire organization and how can they help staff those nuanced areas a little bit differently. So thanks for posting that. And Jennifer Misajet is also posting lots of comments in there too. Thanks, Jennifer. We'll have to put you on the podcast and get you as a guest on some of these ideas too. Anielle Burks, hi Anielle, good to see you. She's asked, what do you foresee as the biggest challenge to adoption and shifting thoughts regarding staffing? Tips to get everyone on board.
Oh, yeah, that's a loaded question, isn't it? Oh, goodness. You know, it's a huge change and it's huge. This obviously is changing the way that people work, the way that our nurses work. And so some of those change management strategies I talked about are going to be your core avenues to really help bring this forth. Executive support, setting the vision and holding to that vision, and giving yourself time to understand the model and how it's working in practice and how it's not, and being okay with making some of those minor changes to it to improve practice. And then I think just being gracious towards each other. We're in it together, the workforce, you know, our nurses, our managers, our leaders. So we're all on the same team. We want to care for patients and being gracious towards one another. But it just takes time. It takes usually 6 months is what I see for any type of change to become more comfortable in regards to changing your staffing, scheduling, or, you know, flexible models.
Yeah. And I think, you know, and Anielle put it in the chat as well. I think, you know, there's this assumption that nurses will leave if they don't have 12-hour shifts, and that's sort of like the gold standard. And I think we have to challenge that. And the only way you can challenge that is one or two ways. One, talking to the nurses and talking about the benefits and sort of marketing what the other options could be. And two, trying it. You know, allowing people to do 8, 4, 2, 1 30-minute shifts. I don't know. I mean, sometimes you got to test this stuff, and there's data out there about different models. And so, you know, check that out. But I think, you know, ultimately you got to try some things out, and it can be in a low risk unit. You know, you're not navigating the ORs and the ICUs necessarily to start this stuff, but you can start in units that have a little bit less patient load or patient acuity, where if there's a stumble, it's not as impactful. And just test it and see what happens, and take data and get user feedback. All of that stuff is, you know, I think if we're operating on assumptions, we're doing a disservice to ourselves. So it's really that change leadership.
Mm-hmm. Absolutely.
All right, let's see if there's any more. Let's see here. Lots of nurses who like 12s because they have multiple jobs. Well, so that's not a staffing problem. That's a culture problem. Yeah, and agree. And Sarah, I know when I was at Kaiser, we had multiple nurses that would work at Sutter and Kaiser and UCSF, and they were able to stack their shifts and get their set days, and then they could work all three of them. Number one, that's not safe. And number two, in a crisis, which one are they loyal to, right? Can you call them to come back to your organization, which might be part of the contract that they have with you? And so, those are things that you have to think about. So if they're working 5 jobs, how safe are they to come to you on day 7? And I think those are things that, you may, well, I'm going to lose that nurse now, but you're also not getting a high quality practitioner if they're working 7 days a week as well. So I think those are cultural things that we really, really have to address, and put into the job description and hold people accountable. And not to stop people from working and getting the pay that they want, but to understand that the evidence says they will literally kill people if they work that long. So it's a patient safety issue at that point, not a staffing issue. At least that's my opinion. I don't know, Danny, if you have any thoughts on that too.
I mean, I understand. I think one thing to help kind of smooth or bring that culture change is, can you use your shared decision making models? So can you develop, your shared decision making for your units to determine, hey, how do we want to go about scheduling, and test it out and really engage them to own their practice in regards to their schedule, their shift lengths, things like that. And of course, as an organization, setting some parameters around, not working 36 hours consecutively, 3 12-hour shifts in a row, or over 16 hours. All those things are important for the organization to hold to. And then working with your workforce to understand those needs and desires, recognizing that, a 12-hour shift is a very long shift. But I understand also the appeal behind it as well.
Yeah, it's one of the perks of being a nurse, right? Your talent is needed lots of different places, but I
Yeah,
think we
absolutely.
can also make sure we're safe as well. So if you need more information, want more information, want to connect with us, you have works.ai if you want to learn more about Works. You have Danny Bowie's Trusted Health email there, and then if you want to talk innovation and those type of things, I'm here as well, drunderstan@gmail.com. So please reach out. And the moment you've all been waiting for related to the book is and the resources we talked about. So for everyone that stayed here and signed up through the end, we will be sending a link within the next day or two that will link to all the publications we mentioned. You will also have a link to a survey that will allow you to put in the address you'd like the book to be shipped to. That will come to you, and you enter that, and then that book will be on its way to you as soon as possible. We'll have the insight study will be attached as well, so you can see some of the data that we have there, and the recording of the webinar will be there so you can share it with your leadership teams as well. And so look for that in the next couple days. We appreciate your time and attendance and questions, great engagement. And if we can ever be of service in any way, we're here to do it. Danny, thanks so much for sharing your expertise, and any closing remarks from you.
No, let's dare to dream and press in and make a difference, and continue to dream about flexibility for our workforce and how to help all of our nurses who are working so hard.
Yep. Awesome. Well, appreciate it, Danny. This was awesome. Thanks for joining our webinar. Have a great rest of your Tuesday, everyone, and we'll talk soon.
All right.